terms of the pros of surface antigen loss, well, I think we all know that this is well-documented, excellent prognosis after S loss, either when that occurs spontaneously or with therapy, and it seems to be a reliable, durable endpoint, which is quite important, that seroreversion to reappearance of S is relatively rare, even with immunosuppression. And that's quite important because it allows us to really have a biomarker for people having a long-term good prognostic outcome. And I think importantly to consider is that regulators really may demand this in terms of new therapies. But the downsides of surface antigen, firstly, there's a high bar, and I'll show you, and most of us are aware, that current therapies rarely achieve this, so it's going to be difficult to get there. But I think probably most importantly is it really may not mean what we think it means. So there's the risk of false positives where you have surface antigen loss, but it doesn't really mean end of productive infection, so without the benefits. Or perhaps more importantly, when we talk about integrated DNA, is that you have false negatives where you have persistent surface antigen loss, but with all the benefits. And I think this might actually be a bigger issue in terms of drug development. And then I think it's important to consider that the sensitivity of the assay itself may be an issue, because when you define S loss, if you use a more sensitive assay, you'll obviously pick up more S, and that with newer assays coming along, that may actually impact on how we define this endpoint. So when we think about the natural history, lots of studies, old studies showing the benefits of S loss, but it's also important to recognize that even persistent inactive disease without S loss is associated with very good long-term outcomes. So that is an important consideration, because if we could identify those people and be certain that it was a persistent situation, we may not need actually to see S loss. The problem with S loss is if you look at spontaneous S clearance rates in this very large systematic review that was just published in Gastro, looking at the spontaneous S loss rates, you can see that they're extremely low. So the pooled annual rate of just about 1% per year, and you can see that the factors associated with are basically the factors of having less active disease. So having lower HBV DNA, starting out with a lower S titer, and having E negative disease. But you can see this is a problem, and as Harry showed earlier, when we look at our current therapies, we don't do much better than that spontaneous situation. With a year of therapy, you can see with nukes about 1% S loss, if that, and even when you combine our best nuke with PEG interferon, you may get to 9% or so, but really these are not dramatic rates of S loss, and this is really the problem. And as Harry also pointed out, this is particularly an issue for patients that are E negative. So we see more S loss with E positive patients, whatever therapy you use, than with E negative. And I'm going to come back to that point in a moment. So when we think about the caveats with S loss, we can really think about what do we mean by this endpoint. So what we're hoping it means is really a loss of S antigen transcription from cccDNA, so that you either have silent or preferably absent cccDNA, and that's sort of our goal of therapy. So if we think about elimination of cccDNA, then you get all loss of the downstream events. That's the goal. Alternatively, you can just transcriptionally silence cccDNA and the same thing happens. So cccDNA is still there, but it's not transcriptionally active, and downstream everything stops. Again, I think we'd all be very satisfied with that endpoint. The challenge is, what does it mean when we get there by a different means? So for example, if we stop S antigen translation, and so I think the most obvious approach here would be using siRNA approaches. It's not so clear what this means, because here you're working a little bit downstream. If I can get it to advance.
Keep pressing.
Okay. Or not. Where am I pointing? Should I be pointing? Okay, now I went too far. But okay, so here we're degrading the transcripts and then blocking the downstream, and then blocking downstream translation. And so that, it's unclear if that actually is the same thing. So whether we just getting rid of the protein has the same advantages. It certainly has potential benefits, particularly in terms of restoring immune responses, but whether it means the same thing's not so clear. But I think the bigger question, and where I'm going to spend most of my time, is talking about the idea of S antigen being integrated into the host genome, because when this happens, you have the potential where you are getting S antigen almost
exclusively off of integrated DNA, and this means that even if you were to actually eliminate all cccDNA from infected hepatocytes and everything downstream was gone, so really productive infection was gone, you may still see surface antigen in the serum. And this is really the big risk for false negatives, so for discarding a potentially very valuable therapy because you see that it doesn't reduce S or doesn't reduce S enough to lead to this endpoint. And I'm going to spend a bit of time talking about integration. So the point being is that I mentioned this at the beginning, that you might be able to see the same benefits without having actual S loss. And this follow-up data from the REVEAL study is suggestive of this, where you see that the group down at the bottom, you see that patients that that start out with undetectable DNA at baseline, whether or not they lose surface antigen or they remain surface antigen positive, their outcome is identical. So this may suggest that those patients with very inactive disease that have persistently undetectable HBV DNA but never lose S, and these are all E-negative patients, that they've already cleared S from cccDNA, and this is all coming off integrated DNA. And this is, we can think about this, but this is important because proving that these patients really are the same as those who are S negative is because really the difference between these two groups right now is the S negative patients we can easily identify by a simple blood test. The S positives, undetectable HBV DNA patients, we have to continue to follow them right now because we don't know that they have the same prognosis as those S negative patients. And that's important. So let's think a little more about the integration issue. And this really came to the fore with the data looking at RNAi, and you can see that there was this marked difference between suppression of S antigen. You see very good S antigen suppression with in E-positive patients, but not such good suppression in E-negative patients. And this raised the question if in the E-negative patients it was because of integrated DNA. And this really nice paper in Science Translational Medicine from last year really clarified this, and I think convincingly proved that integrated S is really an issue, where they looked at the ARC-520 given to chimps and saw the same pattern, that E-negative chimps had a less dramatic response than E-positive chimps, and then went on through a number of very carefully designed experiments to really prove that the E-negative patients had predominantly integrated S. And so the first is they just did it by qPCR, and they looked at the transcripts, so they looked at the total HBV transcripts in black, and those that were coming from the pre-core or core, which would really only come off cccDNA, and you can see in the E-positive patients, that's the majority, so most of it's coming from cccDNA, whereas in the E-negative patients, it's a minority. More convincingly, they looked at deep sequencing, so they looked at the single molecule real-time sequencing, and really the point here is that they found these fusion proteins between the S and the chimp predominantly in the E-negative patients. And also when they looked using just sequencing mRNA, you can see that they saw that in the region between DR1 and DR2, which I'll show you in a moment, they really saw that there was an absence of expression of RNA there, suggesting that these were truncated, and really, again, convincingly showing that this was probably coming from integrated DNA. And why is this? Well, I'll show you in a second. So when we think about integration in the viral life cycle, what it's am I going to turn something off? Let me try the pointer. But so if we look at the integration pathway is going through the double-stranded linear DNA as opposed to the traditional going from relaxed circular DNA. So if we look at this more carefully, and this goes back to some very old but I think elegant papers to really define what's happening here, that if you look at the pregenomic RNA at the top there, and then you see minus-strand DNA synthesis, followed by degradation of the pregenomic RNA was the RNA's H activity of the polymerase, and then the key point is here is whether or not that small little primer then translocates from DR1 back to the other side to DR2, and you can get this circularization of the DNA to form the relaxed circular DNA. If that translocation doesn't happen, so if it doesn't shift back to the other strand, then you have this error in priming and you get this double-stranded linear DNA. And this very nice review from Stefan Urban's group that they published earlier this year, they showed this diagram to show this and suggested that about 90% of the DNA is going towards cccDNA, and about 10% is going to this double-stranded linear DNA, which can be integrated. So once integration happens, it's probably happening from host DNA repair mechanisms and then getting integrated into the host DNA. It technically can happen anywhere, but it's much more likely to happen at this space between DR1 and DR2, and that means that what you're going to get integrated looks something like this, where you're going to have the full pre-S1 and S2 and S with open reading frames with their promoters so that you can get production of surface antigen, but it's shorter than the pregenomic RNA, so you don't get any replication. That's quite important. Although you won't likely get E antigen produced, you could if it's produced by a host promoter. It's separated from its promoter, as you can see there, and the X protein is probably truncated, but it might still be functionally active. So this brings up the question, is there a way to distinguish surface antigen that's coming off cccDNA from integrated surface antigen? And I think this very nice study from the Leipzig group has suggested a way that we might be able to do this. So they've looked, and you can see different phases of disease, and they don't see much difference in terms of the total amount of surface antigen, but what distinguishes those patients with very inactive disease, the IC phase or immune control phase, is they have lower levels of the large surface antigen. And it's thought that these large surface antigen may not be produced off integrated DNA. You may get a truncated form of this, and this may be a way to identify these patients as where that the surface antigen is coming off only integrated DNA. So in the other surface antigen species in these immune control patients may be from integrated DNA, so in other words, they're cccDNA negative or inactive, and all of the relevant surface antigen that you're measuring is coming off integrated DNA. And I think this is an intriguing study, and I think we need more data to confirm that this is true. It's important to know, though, that this doesn't always happen. This is a nice small study where they looked at 2 human hepatoma cell lines that have integrated HBV, so they've got the integrated genome, but neither of them are infected or transfected with Hep B, so they can't replicate the virus. But what they can do is if you transfect them with HDV, they can produce functional HDV. And then importantly, from the Alexander cells, when they have a functional integrin, so they've got the full pre-S1, pre-S2, and part of S, the HDV that comes off of that can infect naive cells. In contrast, when they get a truncated pre-S1, so that the sort of like what was shown in that study I just showed you, where the large surface antigen is not functional, this was not infectious. And so what does this mean? Well, it means that at least in some cases, integrated DNA can make functional large surface antigen proteins. So that means that whether we can use that assay as a marker is not so clear. This was in vitro, but these do come from hepatoma cell lines, which were derived from humans. So this is at least feasibly possible. So what about any clinical data on the effect of integrated DNA? Well, this study just came out earlier this year where they looked at patients where they could identify a small number of patients that had integrated S genes, and they compared their S decline over time. And what you see is that in the first 2 years of treatment, there was really no difference in the S decline, whereas those that had integration had almost no S decline after year 2, so they really flattened off. And this suggesting that both initially the suppression was reducing cccDNA-derived S antigen, but then subsequently the S antigen was coming off purely off the integrant and therefore having no effect. And I think this is a small study, but I think it's intriguing to show that this effect is actually real. So if we start thinking about other ways to look at this, we know for a long time now that quantitative S antigen levels correlate with phase of disease. Lots of studies showing this. You can see in IT patients or immune clearance phase or inactive patients. If you look at those more carefully at the E negative group, they have much lower levels, and you can see that those with E-negative hepatitis have higher levels than those that are very, very low, the LR group. So the question is, are these patients producing S? These are still S positive. Is all of it coming off integrated DNA? So if that's true, if you go back to that first figure, then what you might expect is that if this is integrated DNA coming off in the low replicative group, then you'd expect that you'd have a similar amount of integration occurring in those active patients as well, and then you might have integrated at the bottom, and then on top of that cccDNA derived S antigen. And this is important because it raises a question of when is integration happening and how do we interpret it. Because if integration happens early, you could actually ask the question, why does anyone ever clear S antigen? Because really they should all have integrated S antigen just like the E negative patients, and it's not so clear why. And this study from Mason et al. That most of you are familiar with showed that IT patients, just like IA patients, have frequent integration events. So it means integration's happening early in disease. And interestingly, even in this age-matched study, you see that the patients that have E negative disease, but are age-matched for those that are IT or E-positive immune-active have much larger clones. And the relevance of this is it may be you need to produce more S antigen to actually be able to measure the integrated S antigen. So the clone size is much higher, which suggests that this integration is much more relevant in E-negative disease. The question is why, because it's not clear that this is just about duration of infection when you age match these patients. So this raises the last question of can we use other tools other than S antigen? We're going to hear more about this in the next talk. But if you think about HBV correlated antigen just as an example, and you can see that again this correlates with the different phases of disease. And if you look in the far panel, you can see that when you look at correlated antigen versus surface antigen quantification by phase of disease, I think the most interesting group is these patients that are correlated antigen negative but remain surface antigen positive. Because this is a group where you may presume that those patients are in fact having S coming off integrated DNA, whereas those that remain S positive and correlated antigen positive have S coming off cccDNA. And distinguishing those may be a very useful tool and actually potentially a nice biomarker to identify patients who have functionally cleared but remain S antigen positive. And we'll hear more about this in the next talk. So finally, some key questions. Can we distinguish surface antigen that's integrated from cccDNA? I think this question about using the large surface antigen is an interesting question. Are there other tools to do this? If integration occurs early, why is it so much more relevant in E-negative disease? I think this is something that biologically we really need to better understand. How relevant is integrated surface antigen to disease pathogenesis? We know it's relevant for HCC, but what about for the disease itself? And actually, does the virus use this in its life cycle? There's at least some evidence that this is, in quotes, intentional by the virus, so it's not doing this completely by accident, and there may be benefits for it. And do we need to actually think about it when we're thinking about it as a therapeutic target? Do we need to target integrated DNA, or does it matter? And can we use other markers of cccDNA transcription, like correlated antigen or HBV RNA? But the key thing here is we need to prove that these markers actually correlate with long-term outcome. We know they should correlate with short-term outcome, but we need the long-term studies. So should we use surface antigen? Yes, for now, but for E-antigen positive disease, I think it's probably good and a feasible choice. But for E-negative disease, I think false negatives is a real risk, and I think we have a real risk of giving up promising therapy that doesn't lead to S reductions. So I think we need to think about considering multiple endpoints. Surface loss, of course, would be ideal, but surface antigen with negative correlated antigen or another marker of transcription, or possibly using the large surface antigen as a marker of this. But I think we clearly need alternative ways to predict reliable off-treatment good prognosis other than S loss, but this is the best we have for now. Thank you.